on the problem. But we went in with 3 questions that we had. What does the problem look like on the ground? What are the tentacles and how far do they go? So opioid is not just a health problem. It affects foster care. It affects, housing, employment, all different kinds of things. So how far does the tentacle spread? And what is it that local communities need to get a handle on the problem? What kinds of things can state and federal actors do to help them? And we used a method of listening, which means we went down there not with a bunch of data that we wanted to share with folks, but to hear from them what the problem looked like, and from there kind of get a sense of what government ought to do to get a better handle on it. And we started in Sullivan County, New York, which has some of the highest overdose death rates in New York and some of the highest hospital admissions in the state. We also compare Sullivan County to neighboring Orange County, suburban Orange County, and New York City. And we've conducted more than 150 interviews, and that has taken us everywhere from the DA's office to the judge's chambers to, moms and dads in their homes, all the way to the National Guard and other folks around the state. And we combine our interviews, as you're going to see, with some aggregate data analysis to kind of give a picture of what we're seeing in local communities, how that story fits in with this broader picture that you may have heard about. And the one thing we want to point out about New York is it is a best case scenario. There are a lot of states who are much, much worse off than New York. New York requires all state licensed facilities to provide treatment to anyone who wants it, regardless of their ability to pay. New York forbids insurance pre-authorizations for substance use treatment services, and it doesn't allow 28-day insurance limits on treatment without appeal. So it's taking everybody in, not kicking anybody out. And then the other thing New York has is a wealth of resources, including an agency specifically devoted to substance use services, OASIS, as well as one of the largest drug treatment systems in the United States. So in 2016, New York admitted more people into state substance use treatment programs than any other state. So New York is in the best case scenario, and yet New York still has problems. So these are our U.S. data first, just to show you what the opioid epidemic looks like, that it is highly lethal. And so the latest data show that there were more than 67,000 opioid overdose deaths in 2018, 67,000 overdose deaths total in 2018, and nearly 51,000 of those were opioid related. And you can see the total overdoses and total opioid overdoses, the blue line and the orange lines, they're trending down. So the latest between 2017 and 2018 was the first decline that we have seen in a decade in terms of opioid overdose deaths. So that's a good sign, that's a positive trend. But the problem is that we are still like twice what we were a decade ago. And so the overdose death rate is still far, far too high. The other thing that we know about overdose deaths, and these are New York State data in particular, is this isn't just about kids having fun. So there's a perception out there that these are young people, they're acting like young kids do, and they're taking drugs. But what we're really seeing is that this is affecting people 25 to 64. This is the group that's really being affected by this problem. And what's really difficult about this particular age group is that these are the moms and dads and grandparents. So a lot of this is not just an individual problem, as I'm going to talk about. It creates problems for families more generally. The other thing which you've probably heard about is that overdose death rates have risen really quite quickly in rural areas. So they're on the rise in both urban settings in New York and rural settings, but rural death rates are going up much, much faster. And there's been a lot of attention to opioid overdose deaths and the fact that it is hitting rural communities. And people are trying to understand why, what is happening in rural communities that is leading to drug use, and especially very dangerous drug use using heroin and overdosing on it. And unfortunately, the media has really picked up on this narrative of deaths of despair. So this is a picture that I took from the New York Times, an opinion column that kind of encapsulates what we're talking about, which is a lot of media stories, a lot of the media attention focuses on the fact that this is happening in rural areas. And why is it happening in rural areas? Because the economy of rural areas has really taken a hit. And so people have turned to drugs is to kind of dull the pain or make them feel better, or because they don't have anything else that they can do. Now, this notion of deaths of despair comes from a very famous study by two Princeton economists, Ann Case and Angus Deaton. And what they did is they looked at mortality rates among white Americans living in the United States, and they found an increase.
The broadcast is now starting. All attendees are in listen-only mode.
And they found that people were overdosing, that people were committing suicide, and that chronic liver disease was on the rise. So that would be alcohol use. And they described this kind of pattern they saw as deaths of despair. And they linked it to things like declining wages, limited job opportunities, and fewer marriages. And I think that they may be right that these broader patterns are at play, but that doesn't tell the story, and that doesn't explain what's happening in rural communities and rural and urban communities around opioids, right? It doesn't explain why one family is hit so hard and another isn't, why one community in New York might be suffering and another one might not be. And it's just been a really popular way for media to describe what's happening in rural communities, but it's been especially popular for urban journalists to describe rural communities this way. And we're going to talk a little bit about at the end about why that's, I don't think that this is the case, and why it's particularly harmful to go in and into a community and kind of to repeat these kinds of things or to understand opioids in terms of death of despair. So one of the things that the death of despair label does is that it hides what's really going on, right? We say it's despair and then we don't look any farther, but social scientists do not believe that despair hangs in the air over rural communities like a black cloud, right? Instead, we think that there's concrete mechanisms by which drugs get into communities and mechanisms by which drugs get out of communities, that we fix the problem. And it's really our job to figure out what these mechanisms are, and then to create policy solutions, not that address some kind of broad idea of despair, but these very specific mechanisms to fix the problem. And this picture here on the slide is taken from a 19th century picture. And in the 19th century, they actually believed that yellow fever, which is transmitted by mosquitoes, and cholera, which is transmitted by dirty water, they believed that those two diseases were caused by miasma. And that's one of the figures you can see. And miasma just means bad air. And I think that the deaths of despair narrative really sounds a lot like the 19th century belief in miasma. And while it's true that 19th century cities were really dirty and quite awful places to live and smelled really quite terrible, it wasn't the air that was making people sick, right? And if we focus on something like bad air, we miss the fact that if we eradicate mosquitoes, yellow fever will be eliminated. And if we make sure that the sewage disposal doesn't go into our drinking water, then we won't get cholera and get sick. And I think that's exactly what's happening now, is that we're putting this label despair over something just like they did with miasma that's really much more specific and much more concrete in terms of what we can do about it. And let me explain some of these pathways into communities, especially rural white communities. Again, so we believe that there's pathways into a community and pathways out of a community. And in rural places, there are very easy pathways in and very difficult pathways out. And that is why rural communities have higher death rates. And the pathways into communities changed over time, and there's really been 3 waves of the drug crisis. And so what you can see here are overdose death rates, and if we focus on the blue line, that's all death rates for everybody. And there's really 3 waves to this figure. And the first wave is the introduction of OxyContin in 1996. And so what you see happening after 1996 is an overuse of prescription opioids and unintentional overdose deaths. And then the next wave is the wave when there's increased heroin use. So once patients become addicted to legal prescription drugs, and then the doctor cuts them off, or they're running out of pills too quickly, they turn to the black market, and they turn to street drugs, and they turn to heroin. And, you know, a black market OxyContin pill could cost $40, $60, $80, but a bag of heroin right now costs about $4. So you can see the need if you need to have an opioid, why something like heroin would be attractive. And then the third wave, which you see arise at the end after 2013, is the emergence of synthetic opioids, so fentanyl and its analogs. And that leads to a huge increase in deaths because, you know, prescription opioids are quite, I want to say, relatively safe to use because pharmaceutical companies have measured them, and it's very clear what's in each of those pills, even if you're misusing the pills. But once you get into fentanyl, and people often don't know, they think they're buying heroin or they think they're buying cocaine or another illicit drug, and inside that is fentanyl, and fentanyl is just extraordinarily powerful. You have a third wave of really high increased death rates. So that explains why the pattern looks the way it does. And if we think about race, and especially race in rural communities, the white Americans have had the highest overdose death rates, followed by Hispanic Americans and Black Americans, which are all on the rise after 2013, all on the rise after fentanyl is introduced. But one of the things that we know is that white Americans who have this high death rates also have better access to healthcare and better access to prescription opioids within the healthcare system. So there was a 2012 study that found that Hispanic Americans were as likely to be prescribed some sort of pain medication, but 22% less likely than their white counterparts to receive opioids. And Black Americans were 22% less likely to receive pain medication of any kind, and 29% less likely to receive opioids than white Americans for similar conditions. So white Americans had better access to healthcare system, and within the healthcare system, doctors were deciding pain medications based on race in some parts that colored their perceptions. Now, for types of pain that physicians actually have discretion, those numbers are even higher. So when physicians are prescribing for non-surgical, non-trauma pain, so think of something like a backache or a migraine rather than back surgery or an accident, Hispanic Americans are 30% less likely to receive opioids, and Black Americans are 34% less likely than white Americans to receive opioids for the same conditions. So the data support the pathways in where the problem is hit the hardest in rural areas. So the last slide, we learned why white Americans have such high opioid overdose death rates, you know, in large part because they were receiving prescription pain medications. But physicians in rural areas are also much more likely to prescribe opioids. So this is a map of New York State, and the highest prescribing rates, those are the areas that are the darkest blue, are in the most rural areas. Sullivan County, which we're studying, which is on the border of Pennsylvania, for example, has an age-adjusted prescription rate of opioids of 66.5, while New York City has a rate of only 20, Queens has a rate of only 20.6. It's so rural communities like the one that we're studying are prescribing opioids at a rate that's 3 times what they're doing down in New York City. So the emphasis on rural communities, there may be despair, there may be a lot of difficult economic conditions. I don't want to downplay that, but that's not what's driving opioid overdose deaths. It's easy access to prescription opioids, easy access to illicit opioids, and very few treatment options. So on the left, you see the prescription rate, and on the right, you see the overdose death rate. And what we know is that there's not enough physicians to provide medication-assisted treatment, which gives patients prescription drugs to block the effects of opiate withdrawal. So this is kind of the standard treatment for opioid addiction. So whether it's through methadone use, buprenorphine, and naltrexone, it's just oftentimes not available. And remember, New York State is a best case scenario. So across the country, more than half of US counties lack physicians who can prescribe buprenorphine. And essentially that means 30 million people do not have access to care to treat opioid addiction. And just one person who worked for a nonprofit provider explained, this is the frustration of treatment programs. They keep expanding access to treatment, but if you can't find a nurse practitioner to write buprenorphine, then it doesn't actually matter. So what few people there are who specialize in addiction treatment are hard to find. And county governments and nonprofits cannot compete with hospitals and for-profit providers who can afford to pay much higher salaries. So in Sullivan County, which we had been studying, they had 5 vacancies, including 4 social work positions and a counselor. And the county can't fill those positions because, as one official told us, you can't get something out of a dry well. And let me just show you how this actually works and why access to treatment matters. So this is a map of Eastern Kentucky, and when we talk about states who have real problems, much bigger problems than New York, Kentucky is probably a candidate for one of those states. And Addiction Recovery Care is a treatment provider, and they opened, you can see the blue circles, the yellow circles, and the stars. They opened a bunch of facilities in Eastern Kentucky. This is Appalachia. This is the place that's having really been hit hard by opioid overdose deaths. And after they opened, so what you see those two maps, and you can see that Kentucky is the state that's not labeled in those maps. Those are the opioid overdose deaths. The darker colors mean more deaths, and you can see Kentucky has a big black swath in 2008 to 2012, and then afterwards, 2013 to 2017, opioid overdose deaths in that area fall, and they rise in Indiana, Ohio, and West Virginia. And so, you know, if what we're seeing is deaths of despair, then what we're saying about this map is that basically the black cloud that was over Kentucky, the despair that was over Kentucky, blew into Indiana, Ohio, and West Virginia, and has kind of set over those communities. But if what we're seeing is, as I've laid out here, concrete mechanisms like access to care, difficult pathways out of community, then what we're saying is that overdose deaths fell in response to a new and effective treatment options in Kentucky. Treatment that is not available for whatever reason in Indiana, Ohio, or West Virginia. And these are maps that the federal government made. All right, so the aggregate data that I've just shown or just told you about kind of provides a picture about what is happening in New York. but it doesn't tell us about what communities experience, and it doesn't tell us about what makes it so hard for them to get a handle on the problem. So I want to just tell you a little bit about what it looks like on the ground. And the opioid epidemic is affecting different populations, like as we saw, a lot of rural populations, which matters not only for medical care, but also for the kinds of services that governments provide. And so middle-class families are coming into contact with the social welfare system in their community that they may never have experienced before, because the services provided by the safety net are not like the services that they are used to receiving. And so this is from a conversation with a middle-class mom that we have, and she's talking about her son and her experience her son had. And she said, now they just dump him there with no money, no food, no way to get it. You are on your own. I imagine he was still waiting to get a, I don't know what it's called because it's foreign to me, but help, social service help, I guess. And on the flip side, service providers are feeling the same way. They are coming into contact with middle-class families who feel that they may not need the services that are provided for them or that have been assigned to them. So this is from one provider, and I'm just going to abbreviate this a little bit. And he said they think they are above the services, any kind of rules or any kind of oversight. They think they're above the oversight. Look, my home's clean, my kids are. Yeah, but if you're mainlining heroin when your kid's home, it's a problem in the same way, right? And so he's saying from his perspective that middle-class families who've been deeply affected by this problem are oftentimes the most difficult population to serve because they don't think that they should be getting these services. They don't think they should have to have these services, and they're not very compliant with the services that they're receiving. So opioids, as I mentioned at the beginning, are not just a healthcare issue. They're not even just a criminal justice issue. They spill over into families, foster care, schools, and the labor force. So a lot of the, we went into Sullivan County, we started talking to healthcare and criminal justice people, and they kept referring us to other kinds of officials. And they kept saying, well, you have to talk to the schools, you have to talk to this person or that person. And that just shows the kind of the tentacles that I mentioned at the beginning, how far opioids travel beyond healthcare and criminal justice. And so one of the things that we kept hearing about families over and over again is that it is a family disease, that it can be, in the words of one parent, devastating to families. So families are often the first line. They're often the people that are coordinating care, and they, have a difficult time doing that with all the requirements that it takes to kind of navigate the system. Foster care has also been greatly affected. Researchers, for example, estimate the number of children removed because of parental substance or alcohol use rose from 14% to 34% between 1998 and 2016. And roughly 35% of children whose parental rights, of the children whose parental rights were terminated in 2012 had been removed for parental alcohol or drug use. So more and more children are being put into foster care because their parents use opioids, and communities are having a really hard time. Counties are having a really hard time placing those children because, as I mentioned earlier, the population, it's both mom and dad and grandma and grandpa who might be using drugs. And so the children are not able to be placed oftentimes as they are with a grandparent or an aunt or uncle. And instead they're being taken into state custody and are being sent in Sullivan County. They're being sent out of the county and out of the state. They're being placed in Pennsylvania. And this is very, very expensive. It costs about $22,000 per child in regular foster care placement, but it can go up to, over $80,000 for institutional placements for high-risk children in New York State. And the average cost of foster care is over $50,000. And if you think about what you can buy for the same price, it's about the same as an education at Harvard. And the experience of children in foster care, they're extremely vulnerable and they're at higher risk for experiencing adverse life outcomes such as homelessness, teenage pregnancy, and lower earnings. They're more likely to drop out of school, more likely to experience substance use themselves because of their experience in the foster care system, not just because of whatever it is that took them out of their homes. So it's really creating a huge problem for local communities to place children and for these children to have successful outcomes. It affects schools as well, and even though they're highest among 25 to 64, the effects for grandparents and parents has an effect on the schools, as does the smaller number of youth who use opioids. And finally, they spill over into labor and workforce. So people who have addictions or who have criminal records have a difficult time finding and maintaining steady employment. So, in Sullivan County, they opened up a casino, as did many parts of New York State. And for the people who have or who are recovering from addiction, they have a hard time combating kind of the criminal records that may follow them. All of these problems, which I have just mentioned, are made more difficult in rural areas over urban areas in particular. And the rural challenges that come up with this, one of the reasons that rural communities have such a hard time is that they have a lack of access. So in urban areas, a lack of access means there's the doctor I need to see, but I don't have the right insurance. There's the service I need, that I can't go into that building for X, Y, or Z reasons to get it. But in rural communities, the services just aren't there. There's not enough doctors, there's not enough psychiatrists, there's just the care that people need is not available. That people have a hard time getting to services because there's a lack of transportation. I think every one of the interviews that we did, folks talked about the difficulty because of transportation. Sullivan County is a rural community, a rural county. It's the same size as the state of Rhode Island, but it only has 70,000 residents. So the Medicaid will pay for taxis to medical appointments, but it doesn't pay for transportations for other necessities that people need to do well. It doesn't pay for transportations to the pharmacy or for the grocery store or for work. And ironically, that the lack of transportation does not disrupt the flow of drugs into the county. Again, the pathways in are open and clear, but the pathways out are really difficult. As one mom explained, we can't get a pizza delivery, but we can get a heroin delivery, right? To be so far out that you can't get a pizza delivered, but it can be possible to get heroin put in the mailbox. The other problem that rural areas have is aftercare and housing. So once you successfully complete treatment, once you get into treatment, the wraparound services available that people need for recovery just aren't there. So one lawyer explained to us, once people finish a program, they are forced back into the same communities they come from, and they often relapse. He said aftercare treatment is homelessness. So people are just, and this is another provider that we talked to, thrown back into the street, thrown back into their parents' house. They're thrown back into the same place they were, but without the right tools to succeed. And finally, I think one of the unique issues with rural communities is the capacity, the government infrastructure that's there seems to limit what governments can do. So one provider told us the government doesn't have the resources it needs to deal with this problem. And the local government officials themselves said it's tough for us to compete. So part of the problem is that grants, the state likes to give out resources, the federal government likes to give out resources, foundations like to give out resources based on grants, and those grants are meant to say who has the best idea, where can we get the best return on our investment. And rural communities with a smaller populations may be ineligible, but oftentimes they don't have a grant writer, they don't have the people that they need to put these proposals together. right? So they just lack the capacity to kind of play in the field that larger communities like Albany or Westchester are able to do. So some of the barriers to care, some of the problem that people face is that regardless whether you're in a rural or urban community, that when people go to get help, it's just not available. And that's because, you know, federal flexibility allows physicians at hospitals to treat emergency withdrawal using buprenorphine, and the state of New York has a waiver that allows hospitals to convert every medical bed into a detoxification bed. But hospitals still turn people away because they do not meet the medical criteria for withdrawal. And medical withdrawal means that people have to be experiencing physical symptoms, physical withdrawal before they are admitted. And if they don't have these symptoms, they are sent home. And the symptoms are extremely painful: shakes, sweats, whole body aches, restlessness, nausea, vomiting, and diarrhea. And when you send somebody home who's asking for help, when you send someone home who's addicted, especially to heroin, and you tell them to come back, they don't, right? Because what they're trying to do is avoid that very, very painful process of withdrawal. And hospitals turn people away, and they're supposed to be going instead to a treatment facility, a local community treatment facility, but they have trouble getting into those facilities too. And that's, you know, because an emergency department at a hospital is open 24/7, but a community facility may only be open 9 to 5. And people who want help, people who are ready and asking for help, don't always do it between the hours of 9 to 5. It could be 10 o'clock at night, it could be 2 o'clock in the morning, and they can't get into treatment. They may also be turned away because beds are listed based on the sex of the person. So, you know, it might be a bed for a male or for a female, and that person might not qualify. Treatment facilities can turn people away because of pregnancy status, of a history of contact with criminal justice system, for having a physical or mental disability, because they have a co-occurring condition and they're using medication for that. That people are turned away everywhere because of staffing shortages. So even when the facilities have beds to treat people, severe staffing shortages means those beds in practice are inaccessible to the people who need them. So one of the things that happens is that political leaders, government officials expand eligibility for treatment, but there isn't a nurse to do intake in the facility, or facilities can't find a doctor to write prescriptions. And that means that there's just people who show up for help can't get it, and they're sent away. And so this is, for example, we talked to a nonprofit worker in Orange County, and what her job is to connect clients to services. And she said, hey, we have a local treatment facility and it's a great place. And when I send clients there, they're very happy. And she said, as much as she likes to put people there, no one is answering the phone. These were her words: you have to leave a message and nobody gets back to you. So it can be as simple as, if there's no receptionist to answer the phone or nurse to do intake, people who need help can't get it. And instead of making things easier, federal rules actually make it harder. And so it is much easier to prescribe opioids than it is to prescribe medication-assisted treatment to treat people with an opioid use disorder. So under current law, physicians, dentists, veterinarians, physician's assistants, nurse practitioner, nurse midwives in New York can all prescribe opioid, but federal regulations mean that to prescribe the medication-assisted treatment to help people, you need specialized clinics, trainings, and authorization. You have to get waivers from the federal government, and once you get those waivers, there's a limit on how many patients that you can treat. So the first year you can treat 30 patients. After a year, that number can be 100, and then it can go up to 275. So physicians do not get waivered. I think less than 4% of physicians are waivered to prescribe buprenorphine. And even when they are waivered, they don't treat at the maximum. So even if every physician in the United States who was waivered to provide medication-assisted treatment treated at the maximum, we would still have more people addicted to opioids than we would have slots to help them. And overwhelmingly, the majority of those people who would not get help are in rural areas. And one person explained it this way, like if you're in pain, you just limp into the hospital and say that pain is 8 on a scale of 1 to 10, and you'll get an opioid. And if you try to get medication-assisted treatment, they treat those drugs like locked up like Fort Knox. So another reason that people can't get help is that they have other complications such as family, work, or transportation. So from Albany or from Washington, D.C., it can really be hard to see the problem. So we heard about a problem getting beds from grassroots organizers to the Commissioner of Health and Family Services, but the state bed locator tells us that finding treatment is available. Every day there's more than 1,000 open beds. And the disconnect just goes to show you that what's available on a computer screen isn't available in person for all the reasons that I just mentioned in the slide before, that there are all of these barriers to actually accessing and receiving care. Now, people on the front lines want change. And so one mom we talked to said, if it's a crisis, then why don't you treat it like one? Right? Why do you have me wait? Why do you have me come back? Why do you have me call and see if there's an open slot? Where's the tent? Where's the crisis response team? And this is not unique to Sullivan County. So one counselor in North Carolina I talked to said, you know, this is a problem when you're working with people who are addicted, that she said, you know, we feel like we're thrown away. And she said, we are worth spending money on. We are worth spending time. We are throwing addicts away. We throw them away. They're someone's father, someone's son. I'm tired of us throwing them away. I'm tired of being treated as though they don't matter. And I just want to bring it back to the deaths of despair. And yet, even though there's all of these problems, people are not giving up. And a recent study found that deaths of despair may not actually be associated with these rising death rates that we've seen. And this is a photo of Heather. She's a woman that we talked to in recovery. And this here, it's not that people don't go through a lot, they do. It's just that they have a tremendous spirit or resilience. And this is Julie Pasal, and she lost her daughter, Rebecca, in a drug-related, heroin-related death. And she created a weekly radio show on a public radio station. So what we are seeing in local communities is people not giving up. And so the deaths of despair narrative, the idea that some communities are so awful that they're just giving up and using heroin, doesn't actually fit with a lot of what we're seeing on the ground, which is people are trying to do something about the problem, even people who don't have a lot of resources to do it with. And here's a photo of Des, and he is at a community garden. So he is one of the organizers, to Sullivan County, one of the organizers who created this community garden in a public housing complex in Monticello, New York. And this was a place where drugs were bought and sold, not necessarily by the people who lived in the complex, but folks would come in from different parts of the county or neighboring county and trade drugs here. And he and his colleagues turned that into a public garden instead. So what are the takeaways? What can we learn today from all of this information that I've just thrown out there? And the first thing is that opioids are highly lethal. I mean, one of the reasons that overdose death rates are so high is that this drug is so potent. Heroin is so potent, and it's fentanyl, it's synthetic fentanyl, is even more potent and more deadly. And so just by having something this deadly and this potent on the streets, there's just going to be a lot of overdose deaths. So very lethal, and rural communities have been especially hit hard by these. But really, despair isn't killing people in these communities. There is no black cloud hanging over this communities that's causing people to die. And what I really think what we're seeing is that there is very clear pathways in and very difficult and obstructed pathways out. So people in communities, but especially rural communities, have very easy access to opioids, and they have just a real lack of access to treatment. The other thing, staff shortages make it hard to get help, especially in rural communities. And one of the things, so the Sullivan County doesn't have any psychiatrists practicing full-time there, right? So a psychiatrist would prescribe drugs, especially for folks who have mental health conditions, so that they wouldn't do something like use opioids if they feel that things are really difficult. And so what people in Sullivan County do, or if they have a child who needs help, they go to neighboring Orange County. And the wait in Orange County is 2 years to see the psychiatrist. 2 years for a child is 2 years too long. But not having enough doctors, which is a problem across the country, is much, much worse in rural communities. And so to fix the opioid problem, we need to address not this kind of vague idea of despair, but the very concrete real world barriers that people who need help face. All of the reasons I talked about why people get turned away when they ask for help in the first place. So thinking about how we would treat people who haven't yet asked for it, that's a tougher nut to crack. But in the meantime, while people are being turned away who are ready for help and who want help, I mean, that's the hole we need to plug first and foremost. And that's who we are, and that's, if you want to follow along on our opioid research, we post as we go. So as we have research findings, we put them up online. And I'd love to take any questions that you have.
Thank you so much, Patty. If you do have any questions, you can type them in the question section. Right now, it looks like there are no questions, but if you do have a question, you can email me and I can forward it to Patty to see if she can answer it. Patty, what would be the best email for you?
It's PSTRA as in Apple, CH at albany.edu.
Perfect. And I'm not sure if it got cut off in the beginning, but I just want to say who you are. I think it might have gotten cut off where not everyone was able to hear you. Do you want to just say where you're from real quick?
Sure. I am the interim executive director at the Rockefeller Institute of Government, and we are the public policy research arm of the State University of New York. And I am also a professor of political science and public administration and policy at the University at Albany.
Perfect. Thank you so much. I think there was a little technical difficulties in the beginning, but I think it did get recorded. So if you did miss the beginning, it will be posted to our website as well. But I want to thank you all for listening in, and I hope you have the rest of a great, wonderful day.
Thank you so much.
Thanks, Patty. I appreciate it. Have a great day, everyone.
Bye.